Well, hello and welcome to the 27 Degree with Chris and Nancy. Today, filming from PrimaCare's Endoscopy Center, where we are joined by Dr. David Maddock. Before we begin our tour, I'd like to thank our sponsors, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. And Duncan Hearing Healthcare you can trust with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. As always, you can support the 27 Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platform, and by following us on Facebook and Instagram. Also, please remember to leave a review, and of course, 5-star reviews are greatly appreciated. Dr. Maddock, please tell us a little bit about yourself, and then we're going to view this endoscopy suite, which I'm really excited about.
Hi, I'm Dr. David Maddock. I'm the Chief of Endoscopy and Gastroenterology at PrimaCare, and we've been working here for quite a few years, and we decided to set up our own endoscopy clinic here some years ago, and this is what you'll see today. I'm proud to show you what we do here, where it happens.
And I think this is super great because not only is Dr. Maddock going to walk us through, but anyone that's kind of been thinking, oh, I know I have to get a colonoscopy, but I don't know. Like once you see this facility and just see as we walk through what a patient flow would be, you guys are going to be signing up for your colonoscopies left and right.
I've had 2 of them here.
Yesterday. You have to stop doing that.
And they went really well, so I love the center.
One for fun.
Yeah. So this is obviously the waiting room where patients would first come to check in.
Yeah.
And they would check in here, and after that, I guess we walk into where the action takes place, right?
Absolutely.
All right.
Down here.
So let's do it. Authorized personnel only. I think we're authorized.
We are.
All right.
We got to take it. So I think it's great. It's an old mill building from Fall River, but we've been able to give it that modern interior.
Right. So what part of the center are we at here? What happens here?
So this is what's called the pre and post-op area. So we have these bays in here that give really good privacy. Each patient has their own bay here. They're soundproofed in between for privacy.
Right.
Patients check in here before the procedure, get some details taken, and then afterwards they are ushered through to the endoscopy, which is over there, and then they come back in again afterwards, and they're recovered here before going back out and home again.
I like the fact that the rooms are so private that some places it's just curtains separating
Right.
the patients, and you have hard walls here for each room,
Yeah.
which is nice.
That's super nice. Dr. Maddock, at what point, like if a patient confesses that, well, maybe I didn't take all my prep, I kind of had enough of it.
That never happens, by the way.
I figured,
Theoretically,
I figured.
as you ask about.
But
that,
what's the next step, and how important is it to follow those prep instructions?
It's hugely important because what we're trying to do is cut down your chances of getting colon cancer. And the more we can see in there, the better we can see, the more sure we can be that we're getting to what we need to see. For me to tell you, I've looked hard here and I didn't see anything, or I saw something, it needs to be that I have good visualization.
So you want to be visualizing through mud, basically.
We don't, yeah, we want a clear view. Sometimes it's so clear and sometimes, and it's hard. Some people, despite the best efforts, don't.
Right.
So
That happens.
We
to
work
some of my
we work
patients.
on different protocols after that. So it's not a disaster if somebody comes in and they haven't, but we're used to working with plan B.
Yeah.
But the biggest, most important point is just to stick with the instructions and not modify them because they've been worked out over tens and tens of thousands of procedures to know what works for best.
Okay.
What are the indications? Like when do you have to start getting colonoscopies?
So indications are first if you have a problem and things like bleeding or pain. But the other large volume that we do here is preventive, and it's very effectively preventing colon cancer. And the guidelines have recently brought the age of starting down to 45 for everybody. It used to be
Nice.
50.
It was 50 for so many years.
So many years, yeah.
And now it's 45 because we were recognizing that there were colon cancer cases at younger ages.
Correct. And there was a concerning trend that was picked up a few years ago. People under the age of 55 were finding there's a 1% increase per year over the past several years of colon cancer in that age group. So we want to catch that sooner rather than later. So it's been brought back to 45. And in fact, in this unit, we're finding advanced lesions in 45-year-olds,
Really?
6-year-olds, 47-year-olds. It's sort of shocking.
Like that have been like asymptomatic.
Totally asymptomatic. Just the only
That's
reason you know is we look in, and by getting to one of those lesions early, the outcomes are being shown to be better.
Of
It's not
course.
just in theory, well, maybe it would be. It's actually shown to be an improvement.
How critical is it to find something early? Like, is that a game changer?
Yeah, because even advanced lesions, I have to say, if we find something, it's not all over. We have great surgical services in this area, great radiation, chemotherapy. So there are ways that we can rescue a situation very effectively. But the more advanced the lesion is, the odds start to diminish as to the success. So the sooner you get in there, the better.
I have one last question for you before we move on. There are some tests that you can take at home and like mail in, and maybe can you avoid a colonoscopy on these tests?
Right. So that's a question that comes up a lot. The gold standard for detection and treatment, and it's always treatment is via colonoscopy or surgery. So you get it all in one. You come in the door here, you get your diagnosis, you get your treatment, and you're out the door in the vast majority of cases, and that's the end of it. If you do one of those other tests, then if they're positive, you have to come here. The issue with the other tests are they're not quite as accurate. Their detection rate is lower for cancers and colorectal polyps than colonoscopy itself. And some of the tests aren't what's called non-specific. So you'll get a positive read and there's nothing in there. Or sometimes there are things there that are not picked up by the test. The gold standard is colonoscopy.
Right. I always try to get everyone to have a colonoscopy if they can. And then there are patients who, for whatever reason, are unwilling to do it. And if they're an appropriate candidate, I'll send them for one of the stool tests, whatever. There's a couple options.
Yeah.
But I think the colonoscopy really is the gold standard.
Gold standard. Also, I do notice that some people, when they do get one of these tests, they're terrified until they know what the result is. Whereas you get it one and done here. You come in, you don't know what's going on. You get the test done. It's there or it's not.
Right.
And you get the treatment usually on the spot. Whereas with a card, you're waiting to see what did it really mean. And there's a nervousness. You can see that the pulse rate is increased in people coming in waiting for that result. I've definitely seen that.
What's unique about colonoscopy? I was thinking about this the other day. As far as screening tests go for cancers, it's probably one of the few the screening tests we have where you can go in there and find a polyp, which is a precursor to a cancer, and take it out and prevent cancer from occurring. I'm trying to think if there's any other screening test we do that's like that, and there really isn't.
I think there is.
So it's really unique in that
It is. It's usually a diagnosis and treatment in the same session. Yeah.
Because I think what's important for patients to understand is the polyps that you take out, many of those are, not all, but many are precursors to cancer. So when you take them out, you're effectively reducing the risk of cancer in that patient. If they had stayed there, they would have ultimately probably developed cancer a few years down the road.
Right. Over the past 20 years, we've been doing more and more colonoscopies, and we're finding that the reduction in the whole population colon cancer in each group is about 1/3 reduced. It would be more if more people did it. So if you take all the people, all of them did it, you could probably get this down to a 2/3 reduction. Right now we've got a 1/3 because a lot of people still not doing this test that is life-saving.
I know, it really is. And, there's a lot of cancers out there cancer is always sad when someone gets it, but this is one of those that's so preventable in most instances. Yeah. You can't prevent cancer 100% with any type of procedure.
Nothing is perfect.
But you can really reduce the risk of colon cancer dramatically.
Absolutely.
And the procedure's really not that bad. People are often nervous about it, and I'm sure we'll talk about it as we go through our tour here, but the prep is probably the worst part, and it's really not that bad anyway. So, yeah. So,
all right.
So should we walk through and maybe see where all the action happens?
Yeah. Or do you want to see one of these?
Yeah, I
let's
would
take a
love
look
to
at the
go
room.
into the room. So this is very nice and cozy for the patient.
Yes, but not a dark little tunnel. We have a light source there, sort of window area. So as when you're in here, you don't feel like you're in an enclosed box.
It's not
and there's good air, but there's privacy. So we try to combine privacy, good room, and excellent facilities. We fully monitored, fully computerized. So as we put in the information all goes in here, And in the rooms, we have the information. So it all flows through from A to Z.
Who does the patient see when they're sitting over in the bays? Like
The pre-op nurses. So they meet a nurse who is very experienced at this, and they'll explain what's going on, check their background history, blood thinners, things like that are important to know about before we do this safely, and answer a lot of questions. A lot of questions are answered right here. It's not that you come into the waiting room and next thing you're right in the room getting your procedure. You have an opportunity to talk to somebody here.
Will the anesthesiologist come in too?
They do usually, yeah.
what kind of sedation do patients usually get?
So that's one of the proud features we have with this unit. It's probably one of the best units in this area, certainly in the city, but even if you look into Providence, because we concentrated on an issue that's so important to patients about discomfort. So many patients are afraid, people are afraid of having this procedure because of the fear of discomfort and pain. In fact, I had this come up with a person today. They said, am I going to be awake during this procedure? And I said, well, first of all, we use a medication that we put people to sleep. It's an intravenous medication, but they've had experience in other units where they go and it's a medication that's not as effective. And I asked this person, is there a reason you're asking? She said, well, my friend told me that she'd had a terrible experience where she was at one of the other units and she had woken up during the procedure. So when we set this up, we said, this is not going to be for us. We want people to come here, be comfortable in this environment.
Nice.
Is it unique that I know you have anesthesiologists here that many of them were hospital anesthesiologists,
Correct.
I believe, at one point.
Yeah.
Is that unique to an endoscopy suite?
It's not unique, but the availability of this anesthesia service can be spotty. We're 100% all the time. We have this available. So some places you go, you're not sure on the day, are you getting the good stuff or the not so good stuff? So we said, no, we want people to be reassured that they're not going to be talking to their friends about the fact that they woke up in the middle of this and we're comfortable, to be honest.
Yeah, I mean, the two I've had, I had no recollection of it, quite honestly, which was excellent. So all right.
Then where's the next spot?
Yeah, where does the patient go
So
from
after
here?
after they're all checked out.
So next they're wheeled down the corridor here to this area. And here's our Armenio, who's our chief here at the unit, and our technical staff here who are figuring out some more updates in our computer system. Always employing that.
There we go.
So
There we go.
this is the area. We have a large TV screen here that we use to display what we're looking at.
So now the patient's on the stretcher here, right?
Here, yeah. And this is the work area where we have our scope source here looking across over there.
Is the patient like at this time when the patient's like, if I'm the patient and I'm wheeled in here, am I like out already or am I still?
No, you're awake. You're still awake when you come in here. Yeah.
How
So
quickly do I go out?
we get people to try and count down from 100 to see, and I think the best anybody's ever done has got to 87, but mostly it's like
I
did you get to
counted
98?
maybe like 6. I went like from 10 to 6.
yeah,
And I was out.
Yeah,
It doesn't.
it's rapid.
It's really
and
quick.
the wake up afterwards. There's no major hangover of being groggy for all the rest of the day. Probably within a half an hour of finishing the procedure, people are pretty bright and ready to go. Occasional person for a couple of hours, but we encourage people to go home and rest and take it easy.
Right.
People are able to decompress for the rest of the day.
They still can't drive afterwards, though.
No, not
They
till
have
the
to have
next day.
someone drive them,
yeah,
right?
Yeah, there's
For safety purposes, I suppose.
absolutely. Yeah,
Right.
yeah.
Okay. So you're doing the scope and there, obviously the patient is asleep, but you're viewing everything on this screen that you're seeing.
Right.
Is that
Yeah.
right?
In the olden days, we used to look down the scope directly,
Right.
but now we have high definition TV screens with a large
great.
image, so we're getting a really good view of what we need to concentrate on, and the crew in the room are also observing, and it's easier to work when we all see the same thing that we're working on.
Right.
So state of the art.
Who would be in the room? Yourself.
So we have the anesthesiologist over here. You have me here. We have the tech working with me on the equipment, and then we have our computer system. We have there to monitor to enter all the specimens they go down from there to the lab, and the computers in the lab coordinate with the computer up here. So it's a close following of the polyps. It's really important to make sure that we take the right polyp from the right person and have it all tagged and very, very carefully analyzed to make sure it's all correct. It's not done in any sloppy way.
So you take a polyp out, it's attached to that person's obviously name and whatnot. Then it goes to the lab and they analyze it to see whether or not it's precancerous or whatnot.
And just to emphasize that polyp, a lot of people don't always know what a polyp is. A polyp is a little growth, like a wart-like growth that occurs in the intestine, often the size of a small thumbnail or something like that we can cut out with various instruments. It is not cancer usually, but if it's left there, it can grow over time and become cancerous. On the screening tests we do, about 30% of men and about 20% of women have polyps when we look at people who don't know they had a polyp. So it's not like 1 or 2 out of 100. It's 20 or 30 out of 100.
And with colon cancer, you don't really know you have it unless you do procedures like this until something bad happens, right?
Right.
You're struck or you bleed.
Right. And in those circumstances,
sometimes it can be advanced.
And again, everything is fixable on some level.
Right.
But the later you leave it, the outcomes become less optimistic. But it's extraordinary what in the space of my career, what the surgeons and the oncologists can actually do with some of these lesions. Medicine is getting more and more sophisticated, but you never say to the point where you say, well, just wait till it happens,
right.
And then we'll treat it, because we've shown that is not optimal. That's more likely to lead to a bad outcome. So you want to get it in there before it becomes a cancer, and that's what this offers us here, and especially in those people in their late 40s. I mean, again, it's pretty impressive what we see sometimes in somebody in their late 40s who have just no symptoms.
So how long does an uncomplicated colonoscopy take to do?
So we do a withdrawal time that's at least 6 minutes, and usually more than that, through the colon, looking carefully. Okay. So by the time out of the room, it's a half an hour. Of procedure time, it's usually 15 to 20 minutes.
Then if you have to do a biopsy or take a polyp,
all within that time, we can usually
That's all within that time?
Yeah, usually within that time. Like anything can be complicated, can take 3/4 of an hour when we have to do what we have to do. But the average would be for a small 1 or 2 polyps in a 52-year-old with a colonoscopy. That would be the time.
I know when we talked to the director of the center earlier in the week, he said about 2.5 hours from the time you're parking your car and checking in to the time you're actually just like leaving. He said kind of about on average.
Again, the process, you wait in the waiting room, you go to the room, you get your IV, talk to the nurse, come in here, get your procedure, go back to recover because you have to wake up for a little bit, and then sit and make sure all the blood pressure is stable and stuff, and then go home 2.5 hours often. Yeah.
It's not a big time commitment for a life-saving procedure.
Correct.
You know what's nice too about the center is it's like easily accessible. You're not walking through like 5 miles of facility. It's just like, boom, you park, you go up. Hey, I'm here.
Yeah, and it's here at PrimaCare. So people are used to their doctor's offices where they park for their doctor's office, and it's just another part of the building complex.
Right.
Yeah, it's handy that way.
Right. No, it's super nice. What's next?
Well, maybe up the corridor here, and I'll show you. Again, we're very proud of how this was built. PrimaCare put together a beautiful facility here, in my opinion. And this area, it looks a little techie, but this is the area of where the scopes are processed. I just want to show you.
It's like a behind the
yes,
the curtain
look,
behind the scenes.
the backstage tour.
Yes.
So
it's like the VIP tour.
Yeah, that's right.
PrimaCare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. PrimaCare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. PrimaCare is large enough to take care of all your medical needs, but small enough to care for you personally. PrimaCare is by your side.
Like no one gets to see this.
Not really, but so these are automated cleaning machines here that are run by computers that process the scopes. So, these scopes are in an area that's got a lot of contamination. So we want to make sure these come out pristine before they come into the next person. So they go into these machines. They are cleaned thoroughly over here with magnifying glasses and stuff like that by our crew, and we have a superbly trained and dedicated crew here, and they get these scopes up to standard, and they check them. They actually do run checks on them to make sure they're clean.
So they're like super duper clean.
This
when
is-
they
yeah,
come
this
out
is,
of like, this is high tech.
This is high tech these days, yeah.
Nice.
So, and this is very much state of the art. This is, again, not something you see in every facility to have this level of stainless steel, etc.
Right.
Great.
Good.
You know, a lot of patients, they have concerns. They're always like, oh, I'm worried about a complication, but I've seen so few. I can't even think of the last time of my patients had a complication with colonoscopy. I'm sure it happens, but it's really rare, isn't it?
It's rare. It's 1 to 2 in 1,000 of a serious complication. That's still 1 to 2 or 1,000. But we are putting that risk up against the risk of leaving things go. And as I said, we're down nationwide 1/3 on colon cancer.
Which is one of the more common causes of cancer.
Second main cause of cancer death is colon cancer. So to be able to make a ding on that, the complications are thankfully rare, and you stack up the complications against all the lives saved, and it's, yeah.
So really a procedure that's a lot easier than people think as far as what they need to go through. Pretty low in complication risks, not uncomfortable, and life-saving.
And you're not waking up in the middle of it.
Right.
And yeah, that's what we really want to make sure, that we want to do it well and do it comfortably, do it so as to take away that fear. And yeah, no, that's you put it very well. That's exactly what we want to be doing.
You know, I was just kind of thinking too, like all this stuff we're so concerned about, like our car getting oil changes and everything else. This is our body.
Right.
And like anyone that's like thinking, I don't know if I want to go for the colonoscopy. It's like, you got one. You can't trade it in like you can a car.
And we do see the other side of the coin. We see people come in who haven't had the test done, and they do wait till, they develop symptoms. And it's so tragic, because you see this thing that's large and ulcerated and think, oh, if they only had a colonoscopy at the age of 45 or at, now they're 51 and they've got this big thing. And it's like, oh, if we can only
I'm
get
glad
them.
you're like throwing out the ages too, because it's not like a 75-year-old disease. This hits like young people.
This is, and that's the scary part. It's been increasing in the past few years in younger people. That's why we changed the guidelines from 50 to 45 to pick up on that trend that was happening. For reasons we don't know why this is happening. We don't
Is there
know.
anything in the literature like that?
There's nothing. Is
it like diet related?
There's a million theories we just don't know. We know the phenomenon, and yeah, the diet is we just don't know. We don't know. And there's a lot of people working hard to figure that out. It's not like being ignored, but that answer hasn't come up yet as to why that's happening.
Is there anything in the literature that you're aware of where it's like a certain country has such a low incidence of colon cancer compared to?
It tends to be countries that have not the Western diet and lifestyle. You'll find lower cancer incidences. So there is something to do with the lifestyle, but the lifestyle is so many things.
That's your machine hard at work. All right, let's move on.
Yes, you won't be able to hear us otherwise. Oh, there we go. It stopped. Okay.
You must
Just to
have
show
done
that
something.
these even work when we're not here. They're checking themselves, making sure they're okay.
Or they could be sensing that maybe you need a little shower.
All right, Nancy. Okay.
All righty. Oh, so we passed something very important without
This is
mentioning
huge.
it.
This is
yes.
huge.
Warm blankets.
Like
is
that's a big one.
So these facilities are very clean. So there's a lot of air flowing through that helps things like airborne viruses, like that we've had problems with in the last 4 or 5 years, as you know, nationwide. So this decreases the chance of transmission of airborne illnesses, but that makes people somewhat chilly, and they can be nervous, and it can be winter. So this beautiful machine is a blanket warmer. Sounds very low tech, but it's great. If you're
No,
lying in
that's
a
like the
stretcher, you're
best.
cold, we bring these warm blankets, and pretty much everybody gets a warm blanket.
So, Dave, if I wanted to get one of those for my home, how much would that cost?
Right? Gazillion.
Oh my God.
I think I
Like
need one.
after not waking up in the middle of the procedure, this is the second reason I
That's
come
very,
here.
no, it's very important. Yes.
My wife makes fun of because I'm always cold.
Yeah,
Like,
well,
I'm, I
a
don't
lot
know
of people are. When
Yeah.
you're nervous, you're cold, you get IV fluids in the
right.
cold.
And the IV fluids
They
are cold.
do sell heating blankets on Amazon.
Yeah, I'm going to need to get one of these.
And our staff are great about, I see them all the time. How are you feeling? You cold? We got something for you. And when that goes on, people are like, oh, thank you.
Yeah,
It's very
it's
calming.
just so comfy.
Right.
All right. So now we've had the VIP backstage tour.
Right. So back at the recovery area is now the pre and the post-op is the same. So we have a dedicated group of nurses in the middle keeping an eye on everything. They've got the monitors on the bedside. They've got their computers all updated on what the procedure was and how it went and what the history is and things to talk about, like whether you've been on blood thinners, what happens next when you restart them. But they're keeping an eye on everybody here, and people wake up pretty quickly, sit out, ready to go and meet their family.
So now when they're sitting out here, at like what point do you tell them the results of the test?
We tell them what we found briefly here, and then we do phone them afterwards if there's an abnormal result that we want to talk more about. So occasionally people do need to come to the office. But the fact that they've had nothing, we can tell the majority of people everything was fine. Don't worry. See you back in 5 years. See you back in 10 years. But some results we do have to go over. So
that's a good point you just made about when to come back, the frequency, and it differs based on what's found or family history. Maybe you could talk about that.
So some people think it's a statin. Everybody has it so many years, but it's actually circumstances change. So somebody who's average risk of colon cancer, we do this every 10 years. The beauty of that is that you just need to do this every 10 years. And if it's negative, you don't have to do anything in between times. You don't have to do that, as I call it, the poop in the box thing. Or you don't have to get a card sent home yearly. It's done. You're done for 10 years unless you develop a problem. If we find polyps, commonly it's 5 years afterwards we do that again. And then some of the more complicated polyps will do a sooner follow-up. If you have a family history, colon cancer, we'll do it at maybe a 5-year interval because you're at more risk than a person who's average risk. So,
And you may start a little earlier for those patients.
surely,
too.
yeah. Somebody has had a parent, for instance, that had colon cancer at a young age. We see people with colon cancer, unfortunately, in their early 40s even. So their children might be done in their late 30s, starting off to check it out.
You know, it's another thing that's done here very well is the timing of the discharge instructions. Like you're not giving discharge instructions after the procedure when someone's kind of like loopy. Like that's done before, and that doesn't happen everywhere either.
Right, and sometimes we have to reinforce it. There are times when we talk to people and afterwards they say, what'd you say again? So we come back, we talk again. So as the drugs flush out of your system pretty quick with the drug we use here, people have a high retention rate of what happened. Some of the other facilities that use drugs that are different, people just forget the rest of the day. They don't even know. So there is confusion more. So again, we really concentrated in getting a clean anesthesia approach here where you go to sleep nicely, you wake up nicely, and you're pretty with it pretty quickly.
That's great.
I'm going to book one tomorrow.
Absolutely.
Is there any one message you'd want to leave the audience, our viewers?
Get this done. Because it is, we're not seeing, there's still a lot of people are, for various reasons, not getting this done. And I'm hoping something like this, just showing how the facility is and talking a little bit about how it works, that people will feel more comfortable. Right. You're going to be sedated here and you're going to wake up clear. We can do this in a way that is comfortable. That's what's really important. So please get this done because it saves lives.
Right.
It's not a theory. It's been shown in all the studies. It saves lives.
Right. There's no discomfort, and the prep isn't really all that bad. And whatever minor issues you may find with the prep, it's a lot less than getting colon cancer.
True. And I want to modify that. The discomfort of being awake, we can take away. People sometimes feel gassy afterwards, and stuff like that. So that's an issue. We actually use a different technology than we used in the old days. We use carbon dioxide, which is absorbed quickly in the colon, so we decrease the bloating that people sometimes do feel afterwards. So there is occasional discomfort, but to save a life, that's important. We're trying to answer.
Yeah, it's to potentially save one's life. It's really a very easy thing to go through. It really is. Yeah, most of my patients are willing to do it or have some type of cancer screening for colon cancer. I always hope they'll have a colonoscopy because, as you mentioned, the other tests really are not quite as good, and this is the gold standard. But every once in a while you do have someone who just won't have it done, and you just worry what's going to happen down the road.
Yeah,
And
I
we
know you
still
do a great job persuading people, because
Yeah.
I see some people come in, they said, and I know they're 4 years over their initial thing.
Right.
I said, did you have a discussion with your doctor for the past 4 years? And a lot of the doctors are trying every time. They
Right.
finally say, oh, okay, I'm going to do it. And they're relieved when they come here, because it's been playing on their
Yeah, we're
minds.
fairly relentless, but because, if you have those 1 or 2 patients over your career who were adamant they didn't want to have it, and then they develop, colon cancer, you just don't want to see that again. So, we do push pretty hard. And like I said, all of my patients who have it done, they come back afterwards and they say, it wasn't really an issue, and I'll have it again when I'm due.
Right, yeah, we don't get many people come and then not come again. Once they've come, they usually say, okay.
I mean,
I did it. That
that's
wasn't so
that's a,
bad.
a really valid point, because the first comers who don't know about it, sometimes they're a little hesitant, but once they have it done, they're fine.
Yeah.
Yeah, I'll have it done again. It's not an issue.
Right.
Can I ask one last question? Is this center exclusive just to the PrimaCare patients, or can someone request
Yeah.
to come here?
Yeah, absolutely. So we do.
Nice.
This is not just for PrimaCare. This is for all comers. What we do is we send a copy to the referring doctors from outside PrimaCare. We send a copy of that record.
Perfect.
So if someone is interested in having screening, and hopefully everyone who's watching this, if they haven't, will, they should talk to their primary care doctor, I would assume.
Yeah.
And if they don't have a primary care doctor, what do they do?
They can phone us, and we have a way of getting that done.
Okay.
Yeah, we can work that.
Okay.
Nice.
Great. Nancy, anything else you wanted to ask? Did we
I think
answer all of your
Dr.
questions?
Maddock did an excellent job.
Yes.
Yes.
He's a natural.
Thank you.
Absolutely. This was a great tour. Thank you. I mean, I learned a lot, and I'm sure our audience will too. It's just a great facility, and it's just really great to talk about a procedure that's so, life-saving, basically.
Well, thank you for doing it. Thank you for thinking and asking. It was your idea. Thank you very much, Lance.
Yeah, you're
Thanks,
welcome.
Chris, for putting this together.
Yes. Well, no, it was our pleasure. And I want to thank our listeners for listening to the show. And if you'd like to become a sponsor, please contact us at 774-319-4230. And special thanks to Ron Gamache for our intro music. PrimaCare, your trusted medical providers in Southeastern New England, and BioSkills of Northeast for producing our show, and also available to produce your show. And they do a great job. And their number is 774-301-8811. Bay Coast Bank, just right for all your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. And Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. Thanks everyone for watching this segment, this podcast, and we'll see you again soon.